Hey, not an ordinary fellow here, and I got a page. So let's see the text. So this is a 60-year-old Afro-American male with back pain, AKI, and altered SPAP. So Dr. Hospitalist. It's a common name for hospitalist, Dr. Hospitalist. He's asking for my recommendations because he thinks this patient has multiple myeloma. I just started my fellowship, so I don't know anything about multiple myeloma, and I think I need to study a little bit before I see this patient so I don't do anything wrong. Let's go and crack this case together. So, what's the definition of multiple myeloma? It is a neoplastic proliferation of plasma cells producing a monoclonal immunoglobulin. So the plasma cells proliferate in the bone marrow, and that proliferation results in extensive skeletal destruction and osteolytic lesions, also osteopenia and pathological features. Oh, sorry, fractures. Fractures. How is the clinical presentation? Though usually those patients will have bone pain. They might have an increased total serum protein concentration on the labs, and also they might have monoclonal protein in the urine or serum. In terms of systemic signs, the patient can have weight loss or fatigue, also can present with hypercalcemia and AKI. Neurological symptoms, so it's very important to recognize cord compression because this is a medical emergency, and also hyperviscosity. The epidemiology, so it's 1 to 2% of all cancers and 17% of all hematologic malignancies. The incidence is 4 to 5 per 100,000 and is more common in Afro-American than whites. The rate is 2 to 3 times higher. It's lower risk in Asians from Japan and Mexicans, and it's more common in men than women to a rate of 1.4 to 1, and also the risk increases with BMI. So the median age is 66, and only 10 to 2% are younger, and around 50 to 40, and there are a small fraction that are familial. Having a first disease family member with multiple myeloma increased the risk to 3.7. The clinical presentation, in terms of signs and symptoms, they are always related to the infiltration of the plasma cell to the organs, or I mean the bone marrow and the bone, and also related to the monoclonal protein damaging the organs, especially the kidney. 72% of the patients will have anemia, 58 will have bone pain, elevated creatinine over, over 2 will be seeing 48%, fatigue, weakness seeing 32, hypercalcemia is 28%, and weight loss 24. Also, you can get patients with multiple myeloma or even like smoldering myeloma with an increased total serum protein level without symptoms. Protein levels can be normal also in patients with myeloma, especially if they have only light chain myeloma. as the free light chain seldom rise to a level that affects the total protein. Extramedullary plasmacytoma, they are seeing 7% of the patients, and that can be a disease in the bone or also in the subcutaneous tissue. So the presence of extramedullary plasmacytoma usually is associated with inferior survival. So the anemia is the most common sign of a multiple myeloma, and it is secondary to the bone marrow disease. Also can be secondary to the kidney disease and a large amount of M protein. The bone pain, which is also very common, usually is in the back or chest. So 60% of patients, um, and the pain is worse with movement. And it's interesting to notice that sometimes the patient can have a reduction in their height due to vertebral collapse. The renal disease is seen in at least half of the patients. It is the cause of the light chain cast nephropathy and the hypercalcemia. Patients that do not secrete the light chain are not at risk of myeloma kidney, so they will not have renal disease. In the absence of other presumptive causes of nephropathy, the diagnosis of light chain cast nephropathy can be made if you have a high uninvolved free light chain, over 1,500. Of course, other cause of renal failure in a patient with multiple myeloma can happen. So patient can have light chain amyloidosis, light chain deposition disease, or even drug-induced renal damage. Hypercalcemia is seen in 28% of the patients, and the serum will be at over 11. The ionized calcium should be measured if patient has a high serum calcium level but no symptoms of hypercalcemia. Elevations of serum calcium may be due to binding of monoclonal protein with the calcium. In terms of neurological symptoms, radiculopathy in the thoracic and lumbosacral area is the most common neurological complication of multiple myeloma. Cord compression is also seen, and it's important to recognize that as a medical emergency. And it can be due to a plasmacytoma compressing the spinal cord, or also due to a fracture of the vertebral body causing the compression. Um, this patient should have MRI or CT immediately with the follow-up treatment that can be surgery, radiation, or even chemotherapy. Peripheral neuropathy is uncommon in patients with multiple myeloma at the time of the diagnosis. Of course, they can have peripheral neuropathy due to treatment, especially Velcade. When peripheral neuropathy is present, we have to think about differentiation diagnosis as amyloidosis and POEMS. CNS involvement is kind of uncommon, So intracranial plasmacytomas are very rare, but usually the disease in the CNS will be due to the extension of a myeloma lesion in the skull or also in the base of the skull or the clivus. Leptomeningeal disease is also uncommon. Rare cases of encephalopathy and elevation of ammonia were reported, and it's not clear why it happens, but it happens in the absence of liver involvement and even liver disease. So patients with multiple myeloma, have increased risk due to risk to infections due to immune dysfunction and also physical factors. They cannot walk very much, so they are more prompt to infections. The most frequent pathogens are gram-negative organisms and Streptococcus pneumoniae. So monoclonal protein. So this is a very important topic. 97% will have a monoclonal M protein produced and secreted by the malignant plasma cells. This monoclonal M protein that was produced by the malignant cell can be detected by protein electrophoresis from the urine or the serum. The addition of immunofixation to those tests increases the sensitivity of the detection. The M protein usually presents as a single narrow peak like a church spire in the gamma, beta, or alpha 2 region of the SPAP. Or you can also see it as a dense and discrete band on the gel. So on the next slide, we will be able to see those findings. So here you see protein electrophoresis. So in the gamma region, you have a spike, and you can make the assumption that it's probably a monoclonal disease because it's a single spike. And also on the B figure, you can see that there is a large dense band in the gel representing the spike in the gamma region. So sometimes, but very uncommon, you can see two M proteins, and there will be a biclonal gammopathy. So the malignant plasma cells can produce immunoglobulin heavy chain associated with light chain. For example, elevation of IgG and kappa. They can also produce only kappa, for example, or any light chain, kappa or lambda, or can produce a heavy chain without a light chain. So the most common types of heavy chain will be IgG, 52%, IgA 21%, IgG 2%. IgM is very uncommon. I think it's less than 0.5%. And also you can have like none, you like no immunoglobulin heavy chain elevation. Um, and then you can look into the kappa lambda light chain, the Baines-Jones, and elevation of a kappa lambda alone can be seen in 16% of patients. So there will be a subset of patients with only kappa or lambda elevation without the heavy chain. And they are also negative. In that case, they will be considered to be true non-secretory myelomas in 6.5. So We'll do all the tests, all the SPAP with immunofixation, and also the kappa lambda, and will not be able to detect the monoclonal protein. So in terms of light chain, kappa is the predominant light chain in the bone marrow. Usually is seen in a 2 to 1 ratio. Some of the exceptions are amyloidosis and IgD myeloma, and in those myelomas, lambda is more common. So the SPAP will demonstrate a band in 82% of patients with multiple myeloma. If you add immunofixation, it will increase the sensitivity to 93. And if you, on top of that, add free light chain in the serum or the urine, you can increase the sensitivity to 97%. So this is very good test to detect the myeloma. So patients who lack detectable M protein by any of the SPAP, immunofixation, and free light chain, they are considered to be non-secretory myeloma. And in the patients that with no localized band on the SPAP, you can see hypogammaglobulinemia in half of them. It is secondary to the suppression of the normal gamma globulin production, and also one of the reasons the patients may have an infection. The level of one or both of the major uninvolved immunoglobulin is reduced at 91% overall among all the patients. And in both of immunoglobulin will be reduced in 73% of patients. So up to 20% of patients with myeloma will see only light chain in the serum or the urine, lacking the expression of immunoglobulin heavy chain. So they will not have IgA, IgG, or IgM in the SPAP. They will only have lambda or kappa elevation on the free light chain test. So these patients should of course have a serum a free light chain and a UPAP in a urine immunofixation. Um, in patients with light chain disease, the incidence of renal failure is much higher. Approximately 1/3 of the patients will have a creatinine over 2. Patients with a myeloma who have no M protein in the serum or the urine immunofixation, but have an abnormal serum free light chain ratio, they're considered to be non-measurable free light chain only myeloma. This is just the designation. So patients with myeloma who have a normal serum in a normal urine immunofixation as well normal free light chain, so they are considered to be non-secretory, true non-secretory myeloma. 85% of those patients will have an M protein that can be detected in the cytoplasm of the neoplastic plasma cells by immunohistochemistry, but have impaired secretion of this protein. So that's why we cannot measure the disease, because the immunoglobulin, because it is inside the cells. Patients with true non-secretory myeloma need to be monitored mainly on the basis of tests like imaging, MRI, PET-CT, and bone marrow. Because one of the ways to measure the efficacy of the treatments is to measure the M protein. If it's getting lower, probably the myeloma is going into the right direction. But as you know, in patients that do not secrete any of the heavy chain or light chain, how can you measure their disease? So you have to rely on PET-CTs, MRIs, and the bone marrow. So another definition, oligosecretory myeloma. So 5 to 10% of patients with multiple myeloma, they will have oligosecretory myeloma, which is defined by the absence of measurable disease in the serum or the urine. And the serum M protein will be below 1, and the urine M protein will be below 200. So those patients will be evaluated using the serum free light chain assay and also bone marrow and imaging. Another test that you typically see in patients with multiple myeloma is reanalysis. So, because patients can present with renal insufficiency, and then they will have a reanalysis. So, kidney disease associated with multiple myeloma can also be due to amyloidosis or light chain deposition. So the urine dipstick primarily detects albumin, not light chain. So light chain can be detected by the sulfosalicic acid or a 24-hour urine collection with electrophoresis and immunofixation. So the urine dipsticks is typically negative for protein in patients with myeloma kidney. Uh, but that will be positive in patients with amyloidosis, because most of the urinary protein in those patients are related to albumin. So it's important to understand that if you have much protein, you have much, like a huge amount of protein in the urine dipsticks, you should think about amyloidosis as your differential diagnosis, because the UA should not be positive in a myeloma kidney. And of course, as a hematologist, we always want to see the peripheral smear. So rouleau formations is seen in like 50% of the patients, and the leukopenia and thrombocytopenia are also seen. And plasma cells is found in 10% of those patients. I think that if you do more refined studies, you see more plasma cells. But what I'm talking about is peripheral smears. And the bone marrow is used to evaluate the percentage of a plasma cell, and it is key to the diagnosis. Flow cytometry and immunohistochemistry for CD138, kappa light and lambda light chain should not be used to determine the bone marrow plasma cell percentage, and it can overestimate the result. So mainly we'll be using the morphology in order to determine the amount of plasma cells, not the flow cytometry or even the immunohistochemistry. That's because the plasma cells, they are very distinct and very easy to be counted in the bone marrow. So the vast majority of patients will have 10 or more percent of plasma cells, and it is even one of the diagnostic criteria. Due to the patchy bone marrow involvement, sometimes you can see less than 10% on the bone marrow, because probably when you did the bone marrow, you did not got the area with most plasma cells. And 4% of those patients will have less than 10% of plasma cells. So 4% of all my multiple myeloma will have then less than 10% of plasma cells in the bone marrow. Of course, in order to be diagnosed of multiple myeloma, those patients will need to have a plasmacytoma somewhere else and also additional criteria. The diagnosis of multiple myeloma can be made in patients with less than 10% of clonal plasma cells on the biopsy if other diagnostic criteria and after histopathologic confirmation of a plasmacytoma. And it is kind of the rare situation, and it only occurs in 4% of the patients. Patients who have over 60% of clonal plasma cells in the bone marrow have a risk of progression to end organ damage in 2 years greater than 80%, with progression-free survival of 7 months. So if you have over 60% of plasma cells in the bone marrow, clonal plasma cells, you will probably progress to disease in the next 2 years. This is important because this is a biomarker that can define multiple myeloma. And the immunophenotype, when you do the immunophenotype immunohistochemistry, you should try to detect kappa and lambda light change. And you'll be able to detect kappa or lambda. You should not detect both because that will show probably that these plasma cells are not clonal. The surface immunoglobulin is absent in those patients, and just to have a sense of the normal kappa lambda ratio, it should be around 2 to 1. Ratios of kappa lambda over 4 meet the criteria for monoclonality, so meaning that those plasma cells are clonal. And if you have a kappa lambda ratio less than 1 to 2, probably those plasma cells are producing lambda, so that's why you have this different ratio. So immunophenotyping, so the myeloma cells express CD79, 138, 38, and the VS386. So not common to express CD19, which is expressed in plasma cells. They are also CD45 negative, and 70% will express CD56. In the plasma cell, usually CD56 negative and CD19 positive. So you can use those CDs in order to characterize the plasma cells, improve clonality. So the multiparametric flow cytometry usually detects 6 or more antigens, and those are CD38, 45, 56, 19, and kappa and lambda. The free light change, 90% will have abnormal free light chain ratio. In patients with asymptomatic myeloma who have involved over uninvolved free light change ratio over 100 or greater have a risk of progression in 2 years as high as 70 to 80%. So given this high rate of progression in patients with free light change ratio over 100, um, if you have that criteria met, then you will have a diagnosis of multiple myeloma. So free light chain ratio over 100 is considered to be a biomarker that defines myeloma. And the reason for that is that in 2 years, 70 to 80% of those patients will have progression to end organ disease. So imaging nowadays is considered to be key in patients with suspected multiple myeloma. So suspected multiple myeloma patients should have a whole body low dose CT as baseline. If you have a smoldering myeloma, meaning that you don't have bone lesions or other myeloma features, you should have a whole body MRI or MRI of the pelvis or spine. MRI is more sensitive than CAT scan and PET-CT for focal bone marrow lesions, so MRI is preferred, in other words. In patients with suspected extramedullary disease, meaning disease outside the spine, they should have a PET-CT. Just remember that MRI is still preferred for patients with spinal involvement and concern for cord compression. So if you have back pain, if you have signs of a radiculopathy, you should have an MRI, not a PET-CT. MRI and PET should be performed routinely after the diagnosis of a solitary plasmacytoma or smoldering multiple myeloma in order to detect lesions that will change the diagnosis of those patients from solitary plasmacytoma or smoldering multiple myeloma to multiple myeloma. Skeletal surveys are for patients that cannot have CAT scans, MRI, or PET-CT. Um, okay. Now, in terms of evaluation, what you have to do when you see a patient with multiple myeloma, in terms of history, you have to ask specifically about bone pain, and of course, try to understand how the bone pain is and the location. Also ask for constitutional symptoms as fatigue and weight loss, and special attention to neurological symptoms because cord compression is very important. Um, Also ask for infections and do a good physical examination because sometimes patients just don't see a plasmacytoma, and then you're gonna see that in your physical, and also do a good neurological test. In terms of screening, I think it's there's a many labs you can order. I'm just saying that you can do a screening with a CBC, LDH, beta 2 microglobulin, CRP, kappa lambda, a SPEP with, of course, immunofixation in the UA. Those tests are, I mean, only for initial screening, um, and if you want, you can skip the UPAP because the sensitivity of adding UPAP or the kappa lambda in the serum is 97. So I don't think adding UPAP to those tests will increase the sensitivity. Um, but then if you made the diagnosis of a plasma cell disorder, then you do the UPAP with immunofixation. I'm just saying that because UPEP sometimes is difficult for the patients to collect because it requires 24-hour evaluation. The serum viscosity should be measured if the M protein is elevated over 5, and of course if the patient has symptoms of hyperviscosity, and you should do bone marrow and a fish panel for multiple myeloma. The That's very important. This is the diagnostic criteria. So the International Myeloma Working Group criteria. So this is a major criteria. So you have to have more than 10% of the bone marrow with clonal plasma cells, or a biopsy proven bony or soft tissue plasmacytoma. Clonality should be established by showing kappa lambda light chain restriction. So remember that kappa lambda ratio, and of course you can use flow cytometry, immunohistochemistry, or immunofluorescence in order to make this clonality proof. So in addition to the criteria that we talk about in the previous slide, we can also have we should also have at least one criteria from the crab. So the crab means C is the calcium, R is the renal, A is the anemia, and B is bone. So anemia should be with a hemoglobin below 10, hypercalcemia with a serum calcium over 11, renal insufficiency is a clearance below 40. Usually you should rely on clearance instead of creatinine, because it's more accurate, and also bone lesions. So one or more osteolytic lesions over or equal to 5 millimeter in size on the skeletal imaging. So you have to have at least one lesion in the bone that's over or equal 5 millimeter in an image. It's interesting to realize that if you have a PET-CT with a FDG uptake, if you have osteoporosis or vertebral compression fracture, they are not sufficient to make the diagnosis of multiple myeloma. So you have to have an osteolytic lesion over 5 millimeter or equal to 5 millimeter in the skeletal lesion. So only have a PET-CT with an uptake or vertebral compression fracture is not diagnostic. And always when you have the doubt, you should have a biopsy, because having this bone lesion is the differentiation between having myeloma or other types of plasma cell disease. So there is also some biomarkers that are associated with near inevitable progression to end organ disease. So if you have that, then you have myeloma, because as I extensively talked about before, if you have more than 60% of plasma cells in the bone marrow, you have up to 80% of progression in 2 years. So um, so that would be a criteria for myeloma. Also, the involved over uninvolved free light change ratio over 100 is also a criteria. Of course, having a MRI with more than one focal lesion involving the bone or the bone marrow, and is also part of the diagnostic criteria, as we talked about previously. And most patients will have M protein in the serum or urine. 40% with symptomatic multiple myeloma will have M protein less than 3 grams, and only 3% will be through non-secretory. So through non-secretory meaning no heavy change, no, then this mean no IgG, no IgM, no IgD, or IgA. and also no kappa lambda elevation. So the differential diagnosis is not very broad, but there are some diseases that can progress to multiple myeloma, and we have to make the differentiation, because if you have multiple myeloma, you probably needs treatment. If you have the other diseases like smoldering or amegas, you should not treat those patients. So that's important. So monoclonal gammopathy of undetermined significancy, amegas. What's that? Is this, you have to have a serum M protein below 4, and you have to have bone marrow plasma cells below 10, and of course no CRAB, no lytic lesions, no anemia, hypercalcemia, renal insufficiency. It's important to recognize amegas because it carries the risk of progression to multiple myeloma of 1% per year. And sometimes you do PET CTs and MRIs to follow those patients, because depending on what you have, if they have lesions in the lytic, like lytic lesions, it might be indicative of progression to multiple myeloma. So smoldering myeloma, so it's also important to understand that it's an M protein over 3 grams, and 10 to 60% of bone marrow involvement with clonal plasma cells. And you cannot have, so plus, but you cannot have end organ disease, because if you have end organ disease, this is myeloma. And you cannot also have any myeloma defining events, and you cannot have amyloidosis. So what are the myeloma defining events? So it's end organ damage, so the CRAB, or if you have over 60% of clonal plasma cells, or if you have a free light chain ratio over 100, and if you have an MRI with more than one focal lesion, lytic lesion. So myeloma defining events are important to be recognized, and that's why we have to look for those biomarkers, because if you have a patient with multiple myeloma, and rather than having smoldering multiple myeloma, those patients will have risk for progression in 2 years over 80%. So you have to recognize that to initiate treatment, in opposed to those patients with smoldering myeloma that will not require treatment. The more distant differential diagnosis will be Waldenstrom macroglobulinemia. So Waldenstrom, we'll talk about that later, probably in another video. But what's Waldenstrom? So it's a lymphoplasmacytic lymphoma in the bone marrow with IgM monoclonal gammopathy in the blood. So the lymphoplasmacytic lymphoma is seen in the bone marrow in patients with Waldenstrom, and it can be distinguished from plasma cells seen in the bone marrow from patients with multiple myeloma because of the absence of CD56. And as we remember, CD56 is present in multiple myeloma. And also the presence of substantial small lymphocytic component that express clonal surface immunoglobulin, which we remember it's usually inexistent in plasma cell clonal disease from myeloma, in CD19 and 20. CD19 is, as we talk about, is usually negative. So they are different in terms of the CD expression, especially the 56. So 56 is usually present in the lymphoplasmacytic lymphoma and negative in the myeloma, and of course 19 too. Also, some patients with multiple myeloma, they will have the translocation 1114. And those patients will have lymphoplasmacytic or small mature plasma cell morphology in the plasma cells in the bone marrow. And they will also express D20. So that makes things tricky because you can sometimes mistake the diagnosis with lymphoplasmacytic lymphoma in a possible Waldenstrom. But you have to remember that the translocation 1114 is not seen in patients with Waldenstrom. And also, I think that the translocation 1114 usually will have IgM. Mayo Clinic has specific guidelines to recognize multiple myeloma IgM with a translocation 1114. So also another diagnosis could be a solitary plasmacytoma. So plasmacytomas are tumors composed by plasma cells, and they are identical to multiple myeloma. So you had a biopsy of the plasmacytoma, and it is only there because when you see a plasmacytoma, it meets one of the criteria of a multiple myeloma. So then you have to go and do the whole workup to evaluate for multiple myeloma. And of course, you're gonna have a bone marrow. And if the bone marrow is negative, then it means that it meets one of the criteria for solitary plasmacytoma. The MRI of the spine and the pelvis, they should be normal too, because patient should have a solitary plasmacytoma, not lytic lesions. And also you should not have the CRAB criteria, so you should not have lytic lesions, anemia, hypercalcemia, and renal insufficiency. And amyloidosis. So amyloidosis is another topic, but we'll briefly talk about that as um, differential diagnosis. So amyloid light chain amyloidosis is a plasma cell proliferative disorder associated with the overproduction of monoclonal light chain. Patients with light chain amyloidosis develop tissue deposit of amyloid fibrils of non-fibrillar material that can produce the nephrotic syndrome, heart failure, and hepatomegaly. So all the diseases caused by the deposition of amyloid in those tissues, causing damage. No, so light chain amyloidosis usually demonstrate less than 20% of bone marrow plasma cells. And of course, they cannot have lytic lesions, and they only should have a very modest amount of kappa lambda proteinuria, kappa or lambda proteinuria, so the Baines-Jones. And the diagnosis is made by biopsy of the tissue. So you can do biopsies of the heart or the fat or even the kidney. And POEM syndrome. POEM syndrome is another topic, but Just a quick overview. So it's a polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, skin changes, monoclonal plasma cell disorder with symptoms of peripheral neuropathy, osteosclerotic lesions, Castleman disease, organomegaly, endocrinopathy, edema, skin changes, and papilledema. So they are usually associated with elevation of VEGF. So let's talk about that later. But you have to remember that's part of the differential diagnosis. And of course, another possibility is to have a metastatic carcinoma. So remember that you can have a myeloma with metastatic carcinoma, or you can have metastatic carcinoma with a myeloma. So you should always think about a biopsy. So in summary, it's very important. So multiple myeloma is characterized by neoplastic proliferation of immunoglobulin producing plasma cells. Most patients with multiple myeloma present with signs and symptoms related to the infiltration of the plasma cells into the bone or other organs, or to the kidney damage from excess light chain. Common presentations include anemia, bone pain, elevated creatinine, serum protein, fatigue, and hypercalcemia. Less commonly, the patient will have emergent presentation with a spinal cord compression or severe hypercalcemia. Second point, in patients with suspected myeloma or related disorders, appropriate initial screening tests include the serum protein electrophoresis with immunofixation, serum free light chain that can be in the urine or the serum. A 24-hour urine collection of electrophoresis and immunofixation must be done always once you have the diagnosis of the multiple myeloma, but it can be skipped in patients when you don't have the diagnosis. Further evaluation to confirm the diagnosis of multiple myeloma includes the bone marrow and the biopsy, and of course imaging, CBC, and the chemistry. The diagnosis of multiple myeloma requires more than 10% of clonal cells in the bone marrow, or a biopsy-proven bony or soft tissue plasmacytoma, plus one of the following criteria. So presence of the related organ or tissue impairment that can be attributed to the plasma cell disorder. The CRAB criteria, remember, calcium, renal, anemia, and bone. And also the presence of a biomarker associated with a near inevitable progression to end organ disease. For example, 6% of plasma cells, clonal plasma cells in the bone marrow, or uninvolved rated over 100. Also, MRI with more than one focal lesion. So infiltration with malignant plasma cells may be focal, recurring aspiration, biopsy at multiple sites. Imaging with MRI or a PET-CT can be very helpful. And of course, the differential diagnosis include MGUS, smoldering, myeloma, Waldenstrom, solitary plasmacytoma, amyloidosis, Poynes, and metastatic disease. Thank you so much. Please subscribe to my channel. I'll be doing more of those videos because I get lots of pages, and let's work together. Thank you so much.